And good afternoon, and welcome to the Leadership Webinar, Making Sense of the Policies Behind Healthcare Reform. My name is Janine Hopkins. I'm a principal at Santis Health, and I'll be presenting this session along with my colleague Dan Carbon, who's also a principal with Santis. And we have the great support of a project team here for any technical needs. This is the second of two webinars this month, and it's designed specifically for leaders in the primary care, mental health and addictions, community and home care sectors. And this series is unique in a number of ways. And first of all, because it's a collaboration between the 5 associations representing all of your sectors. And this is really the first time that this kind of an initiative has been undertaken by the 5 associations representing home, community, and primary care. We want to allow a high number of participants, so we are holding several of the same webinars throughout the day for each of the sectors. This webinar right now is for the OCSA members. I want to also just take a moment to really thank the CEOs and the leadership of the associations for taking this initiative on, and for the invaluable advice that their staff and a number of your member organizations provided in developing the content for these webinars. So I just want to take a moment to go over the purpose of this webinar today and the agenda. The first webinar that some of you took part in last week really provided an overview of the health policy and health system. It was meant to be foundational and really to set the stage for what we're going to talk about today. This is the second webinar, and it's really the whole point is to take a much closer look, to look at a more granular look at the health policy and political dynamics at play in Ontario, and to look also at what's going on in terms of reform right now, the Patients First reform. What are some of the reforms and trends that will continue no matter what the outcome of the election is and beyond? And we're going to really delve into top of mind topics like integration. So of course, we're really mindful of the fact that we're having this discussion in just over a month before we go to the polls in Ontario, and there's a lot of time of questions and uncertainty about what the government will look like going forward. But we hope that you come away from this better prepared for whatever change happens, and you also have a better understanding of how your organizations can advance positive solutions. So we will today be sharing information about the key players in the healthcare ecosystems. These are the roles that will continue regardless of whatever government comes into place. The individuals, the faces may change, but the roles will be the same. We'll also talk about the trends and challenges that all governments face and the likely direction that governments and planners will continue to take. And the last section is really about what the 3 main political parties have stated or signaled about how they're going to address these challenges. We'll talk about what's likely to continue, as well as what may change and what are the implications for your organizations. And lastly, we'll leave you with thoughts about how you, as a leader, can not only keep moving forward in an uncertain time, but actually actively participate and shape the solutions on the ground in the system. So just to briefly go over the agenda and logistics for the webinar today, we designed the agenda to be interactive. There will be a lot of time in presentation hearing from us, but we really want to encourage people to share not only their questions, but some of their observations, experiences around some of the things that we'll be discussing. We very much want this to be a dialogue. We found in the first series of webinars that the dialogue and discussion was really valuable. So we encourage you to pose questions throughout, and we will be stopping at 3 points right after each section of the presentation to go over questions that have come in. But as you think of them, please send them to us. The entire webinar is 90 minutes. So following this introduction, there's 3 sections, and each section will be followed by the Q&A. So just want to go over a few logistical things. If you have any technical problems or questions, please call this 1-888 number. It's 1-888-259-8414. That's 1-888-259-8414. This number was also provided in your meeting package, and you need to reference the web ID number. If for some reason you didn't get this number, you can send us a chat message anytime, and we can make sure you get assistance. We'll be using the chat feature for you to ask questions and make comments. It's located in the bottom of your control panel. You simply click the plus sign beside the word chat and you can type in your message. We have a team here that's going through the questions that we receive, and we're grouping them according to the most common themes. We'll do our best to answer as many as we can. There will likely be some questions we won't be able to get to during the webinar, so we will be collecting all the questions and answers, and the associations are quite happy to put out a Q&A after with a range of additional questions that were received. And the webinars will be available on each of the association's websites, so anyone can view it if they missed today's presentation. So with that, I'm going to ask Dan Carbon to cover the first section, which is a closer look at the politics of Ontario's healthcare system.
Thanks for that context, Janine, and overviewing the agenda. I'm sure many of you are starting to pay much closer attention to Ontario politics these days, given that we're on the verge of a pretty interesting election campaign. Where I'm going to start things off today is with an overview of the importance of healthcare itself as a ballot issue in provincial politics and the relationship between healthcare and electoral politics. We're then going to provide an overview of the three main political parties in Ontario and the roles that their leaders and other elected officials play in the health portfolio. When you're trying to advocate for change on behalf of your organization or your sector, it's vital that you're able to approach the elected officials in government in a way that appeals to both the broader philosophy of the party in government, but also recognizes the personal styles and perspectives of the individuals in decision-making roles. People really matter and relationships matter when you're trying to drive change. In a ministerial system, cabinet ministers are often given huge latitude to make decisions, even if those decisions are not in full alignment with the premier. So as we go into an election campaign, you need to keep in mind that it might be just as relevant to you in the health sector to understand who are likely to be future ministers of health in new governments, as is who could be premier after June 7th. We're also going to be reviewing the key roles and personnel within the Ministry of Health. Last week in the webinar, Janine provided a pretty in-depth overview of the role that the ministry itself plays and the interaction between ministry civil servants, political staff, and local health integration networks. In many cases, it's the interplay between the Premier, the Minister of Health, and top civil servants in the ministry that shape the strategic decisions that are made by new governments in healthcare. Healthcare is inherently political. You know, the provincial government is accountable for the performance of the healthcare system, and in many respects, elections are significantly impacted by public perception related to healthcare. These are some of the headlines from the last 4 years. Some actually just before the last provincial election, where folks like Nanos Research, a polling firm, were looking at the perceptions of the importance of healthcare in the Ontario public. What's interesting is that it's really remarkably consistent over the past several decades. When you ask people about provincial politics and the issues that are top of mind to them, the most important issues, their priorities, the things that'll influence their vote, they generally report back two things. The provincial government's healthcare performance and how the economy is doing. And it's usually that healthcare is the #1 concern of the public, with the economy slightly behind in second, although that dynamic tends to flip in times of economic concern or stress. The thing about healthcare, as it's understood by political actors, is that governments usually don't win campaigns on healthcare, although they can certainly lose on healthcare. Healthcare is, of course, the biggest thing that provincial governments do. It's almost half of the budget and over $50 billion enterprise in Ontario. But more than that, it really directly touches everyone in profoundly emotional ways, in ways that many other things that government do not do. What it means is that this dynamic is that in every provincial election campaign, there's in a way a little bit of a mini referendum on the incumbent government's performance on the health file. And you really clearly saw that in 2003, when widespread dissatisfaction with the Conservative government's handling of the health file was a major catalyst in the election of Liberal Premier Dalton McGuinty. There's a question as to whether you're seeing this dynamic emerge again. And as noted, healthcare is remarkably personal. People's views are informed not just by what they read in the newspaper on a daily basis or see on TV, but really, most importantly, by their direct personal experiences and interactions with the healthcare system itself and the experience that their loved ones, friends, and families have. You know, millions of Ontarians every year access primary care, go to walk-in clinics, rely on home care services. Something like 2.5 million individuals a year rely on emergency rooms. So those personal direct experiences with the healthcare system, when all put together, really generate an individual sense of how the healthcare system is performing and whether things are getting better or worse in the Canadian healthcare system. So for the party in power, the incumbents, in this case the Liberal Party, their job during a campaign is generally on the health front is to really remind the public about all the wonderful investments that they've made in healthcare and highlight how those investments are improving care. That's why over the next 6 weeks before the campaign in June 7th, you'll see the Premier and others in government going to communities and highlighting new investments. It might be in family health teams. It might be at the rebuilding of the Sick Kids Hospital, the massive expansion in capacity of the Trillium Health Center. It could be a new long-term care beds. What the government will be trying to do, the Liberal Party will be trying to do, is point to tangible investments that people can really grasp and understand that there's a sign of progress. The job of the opposition parties is essentially the inverse. They need to successfully prosecute the claim that government has broken the healthcare system and the province needs a new hand on the tiller to fix things. And that kind of dynamic is why right now you see the NDP and the Conservatives talking so much about hospital overcrowding and hallway medicine. Some of you might have even just in the past couple of days seen election ads about these topics. Now, what's notably absent in these discussions is usually a concrete and detailed discussion by any of the parties of a plan to address some of the fundamental challenges in the healthcare system. And former Prime Minister Kim Campbell was famous for remarking that, quote, an election is no time to discuss serious issues. And in healthcare, she's definitely spot on. Opposition parties who might have very, very different views on how the healthcare system should be funded, structured, and operated, will usually confine themselves during the pre-election period, during the campaign, to a general discussion of how they'll, quote, fix the system or clean up the mess of the government. While they're happy to talk about how they might make new investments in the system, they generally shy away from raising any bold or controversial ideas that could spook voters. And I think this is because for all the flaws in the Canadian health system, and as we mentioned last week, Canadians remain remarkably attached to the overall model that we have, express high levels of satisfaction with it. And when it comes down to it, very few people are actively calling for massive disruptive change to the healthcare system, and the political discourse reflects that reality. So just a reminder that the election date is June 7th, 2018. We hope all of you take time out of your busy schedules to exercise your democratic rights and responsibilities to make your views heard. It's also worth noting, though, that there is a municipal election this fall. And federal elections next year. So we're kind of in a bit of an election season. And as we mentioned in the webinar last week, the municipal and federal governments both have key roles to play in healthcare. So it's worth paying attention to those as we move closer to the election dates as well. So to put things in context, we've included some of the electoral maps over the past 15 years. There have been, the Liberal Party has been the party of government since 2003 for going on 15 years now. And for most of that time, with the exception of 2011 to 2014, they had a majority government. What a majority government means essentially is that they have over 50% of the seats in the provincial legislature and control both the executive and legislative arms of government, can very effectively move through a legislative agenda and the business of government without really having to negotiate or concede to opposition parties at all. In a minority of the government, however, that situation is very different. The government controls less than 50% of the seats in the legislature, and to pass key pieces of legislation, including matters of confidence that allow them to continue governing, things like the annual budget, they need to make a deal with opposition parties to support the legislation so it goes forward. So in 2011, the Liberal Party essentially got the support of the NDP for matters of confidence until the government collapsed in 2014. Across Canada, minority governments, the history of them is that they're tremendously unstable and tend to have a lifespan of only around 18 months. So if we have a minority government emerging after June, which is always a possibility, that really changes the dynamic pretty significantly. One of the things to note here is that all of the parties running are promising significant change, responding to widespread polling that the electorate is looking for change. But how parties are responding to that call for change differs or is very different. The Liberals are promising a change in policy direction under the same party leadership, while the PCs are promising fundamental change that would move the province away from what they consider the negative aspects of the Liberal legacy. The NDP is also putting forward its own plan for government that they claim represents fundamental change from both what the Progressive Conservatives and the Liberal government would offer. You as organizational leaders need to understand and prepare for the change that election cycles bring. However, as Janine will talk about in much greater detail, the trends and realities impacting healthcare transcend political parties and ideologies. The basic undercurrents of change in healthcare are ones that governments of any stripe need to tackle and that you need to keep in mind through the often heated rhetoric of election campaigns. You know, Ontario has really tended to favor incremental change over big bang in healthcare. And you've seen that through parties of different stripe. And it's worth keeping that in mind as we enter the election cycle. One thing also to note is that the election cycle, the period that we're in, is tremendously fluid. Despite polls that at the moment suggest that we might be heading towards a significant majority government for the Progressive Conservative Party, it is worth noting that these polls that the electoral attitudes of the public often shift pretty significantly within the election framework, and that polling across the Western world, particularly over the past 5 years, has a pretty dismal track record. When you look at the issue related to Brexit in the UK, the election of Donald Trump, or even in Canada, elections just going back in Ontario to 2014, when many polls suggested a week before the election that then Conservative leader Tim Hudak would form a majority government. It is worth noting that the situation is fluid and evolving, and that we really won't know for sure until after the election on June 7th what the shape of the government is going to look like. So I'm going to talk a little bit now about the key political players in each party, and I'm going to start with the Liberal Party, the incumbent government. And as you all know, Kathleen Wynne is the Premier. But regardless of whether it's Kathleen Wynne or someone else as Premier after the election, it's important to keep in mind the role of the Premier in healthcare. And the Premier really plays the executive leadership role in government, and they select the Minister of Health. The Minister of Health essentially reports to the Premier. The Premier sets the mandate for the Ministry of Health and articulates through a mandate letter what is really expected, what is really the job description for the Minister of Health, what are they expected to achieve, what does that performance framework look like? And the Premier provides strategic oversight of the health portfolio. In contrast, the Minister of Health is responsible for the day-to-day oversight of the Ministry of Health and accountable for ministry performance. And the minister is really the final, maybe the easiest way to think about it, is the final decision maker of the Ministry of Health. So when any of your organizations get funding letters that come from the Ministry of Health, or when a new regulation is signed off, it goes through the chain of command in the Ministry of Health, and the final signature in that process is always the Minister of Health, where accountability rests. The current Minister of Health is Dr. Helena Jaczek, who would only remain in that portfolio if the Liberal government is re-elected and the Premier would like to continue her in the portfolio, although initial indications are that her performance has been well regarded within the government. I'm going to move on to the Progressive Conservative Party. The leader of the party, Doug Ford, who just recently took the role after a scandal related to previous leader Patrick Brown required a change in leadership. Doug Ford is running not just to become Premier in the upcoming election, but he's also running for a seat in provincial parliament in Etobicoke North, which is a kind of interesting dynamic. If he became Premier, he would really face the similar roles and responsibility, opportunities and constraints the current Premier Kathleen Wynne faces. So strategic oversight over the health ministry and direction to the health minister. The current critic for health, Jeff Urich, is actually a health professional by background. He's a pharmacist from rural Ontario. He generally seems well respected and well liked within the health sector. And Jeff's role as health critic, like the role of the health critic for the NDP, has been to raise issues that question the government's health policy agenda and try and shift support away from the government on the health file, and to also, very, very importantly, advocate for those who are concerned about the direction of government health policy or the direction of other government agencies, such as local health integration networks or others. In the case of an election victory by the Progressive Conservative Party, an open question, well, who would become the Minister of Health? Jeff Urich is obviously well positioned for consideration. Another key name that folks need to be aware of is Christine Elliott, who was formerly a PC health critic, a multiple-time candidate for PC leader, and quite recently served as Ontario's first patient ombudsman, knows the healthcare system very well, and has had quite a long period of time of active engagement in the health file. Now moving on to the third party, the NDP. So Andrea Horwath this is her third election campaign. She's very seasoned in that respect. In fact, she's the only party leader going through a third election. It's the first for Doug Ford and the second for Kathleen Wynne as party leader. Andrea Horwath consistently in public polling is reported to be amongst the public the most popular political figure with the highest approval ratings. She's traditionally, and the parties had traditionally had a challenge translating that likability or popularity into support come election day. So it'll be interesting to see if, as the NDP positions themselves as an alternative to the Liberal government on the progressive side of the political spectrum, if that changes in this election cycle. The key player for the NDP on the health portfolio as an elected official is Franz Jelena. And many of you may know Franz or have interacted with her in the past. She has a strong background in healthcare. She worked in the community health center world in Sudbury Nickel Belt before going into politics, and has served as the NDP health critic for over a decade. So she really has a very good, solid grasp on the healthcare dynamics within the province. And then finally, we wanted to touch a little bit just on the federal role in healthcare, and we went into greater detail on the federal provincial dynamics last week. But we do want to note that the current federal government has a more prominent, plays a more prominent role in health policy direction than the previous government. And that's in large part because they've been pursuing a more activist social policy agenda. And you look at things like, not just like the health accord, but also issues related to the legalization of marijuana, the opioid crisis, and medically assisted dying. All of these issues have required new levels of provincial federal coordination and interaction on quite complex and often contentious issues. The federal government, the Liberal federal government and the Liberal provincial government have tended to work very, very well on these issues and others. And there's a question going forward as to whether there's a change in government in Ontario, how it would affect this partnership. It is worth noting, however, that throughout most of Ontario's history, there's been different parties in power provincially and federally, and the kind of conventional wisdom for a long time was that Ontario was better served by having a different party in power provincially than federally, because that provincial leadership could really advocate with elbows out a little sharper with the federal government to get a better deal for Ontario. So it'll be interesting to see how this dynamic evolves if indeed there is a change in government in Ontario. Now I'm going to transition a little bit to talk about the civil service. And the civil service is sometimes referred to as the eternal or perpetual government. They stay in place, free of the winds of political change. The role of the civil service and the Ministry of Health is to be politically independent advisors to government, to implement government policies without prejudice, and to operate government-run programs. It's worth, I think it kind of speaks for itself looking at this org chart, that trying to figure out the Ministry of Health is not a simple endeavor. It is a large and complex organization. There are 94 executive roles identified on this organizational framework alone, which we think is the most recent version out there. The role that the Ministry of Health has played in the healthcare system has really shifted and evolved over time. When LHINs were created, and it was expected that LHINs would take on a role for oversight of 2/3 of the healthcare system budget, the thinking of the deputy minister and the minister at the time was that the Ministry of Health would shrink significantly. And they talked about the ministry rising up to a more strategic level, taking on a system stewardship role where it was focused on setting policy direction, overseeing standards and oversight, accountability, and performance for the system. What happened, though, as the ministry moved to adopt this more strategic, streamlined role, is that there was a sense that the ministry lost a lot of the subject matter expertise, that it didn't really understand as well what was happening, within hospitals on issues related to hospital funding reform or within home and community care, that the technical expertise related to the provision of health services had been lost a little bit within the Ministry of Health. So what happened after that change, and particularly under the tenure of Deputy Minister Bob Bell, is that the ministry has kind of rebuilt a lot of that subject matter expertise. So it's reconstituted a hospitals branch, and it's invested in subject matter expertise in home and community care and other sectors of the ministry. But it has created a much larger, more complex bureaucracy in the Ministry of Health, which some have criticized and others suggest is reflective of the fact that the ministry is responsible for overseeing almost half of the government budget and $50 billion in annual expenditure, and that's a big job. So the way Deputy Minister Bell has been trying to manage this complexity is essentially by relying upon a team of 3 senior executives that will manage a whole host of programs underneath them. And I'll try and explain a little bit of how this is supposed to fit together. Laurel Taylor, her role is a little bit more clear-cut, is responsible for information technology, information management, information needs within the ministry, oversight of the e-health agenda for the government. Sharon Lee Smith is notionally responsible for the overall strategy for the health system, policy and transformation, whereas Associate Deputy Minister Nancy Naylor is responsible for delivery of services, implementation, and accountability, making sure that we're actually getting what we expect. In practice, however, it's as you would expect, it's not as clean cut as that. And if you look across the divisions between Sharon Lee Smith and Nancy Naylor, from a programmatic perspective, if you're an agency in the mental health and addiction space, you're actually working through a different ADM than if you're in the hospital or home and community space or primary care space. Now, for you folks on the webinar today, your associations and many of you directly, the most relevant person on a day-to-day basis would be Amy Olmstead, who really is understood. The expectation is that she's the subject matter expert, understanding all of the dynamics within the home and community care sector, understanding the impact of rate freezes or rate increases, understanding the dynamics between competitive bidding, the shifts between CCA or the integration between LHINs and CCACs and the impacts on the sector. She's within the Ministry of Health expected to be the person who informs not just her boss, Nancy Naylor, the ADM, and Nancy's boss, the deputy, but is also the expert advisor briefing the minister and the minister's office on issues related to your sector. So I'm going to finish off with just a very short kind of scenario that I think reflects some of the interplay between civil servants and the political arm of government. And we're going to talk a little bit about the role of the CCAC. and how that evolved. And what's interesting here is if you think about the creation of the LHINs in 2004 or 5, a lot of the background policy work that was done on models related to regionalization was done by civil servants within the Ministry of Health. And amongst those proposals at the time was a suggestion that maybe CCACs and LHINs should be one entity. But at the time, when the government was moving forward, the political decision was made by those political actors who have ultimate accountability, democratic accountability to the public, to keep LHINs and CCACs separate. Of course, as you all know, the irony here is it took about 10 years, and then the government responding to public pressure and opposition pressure that LHINs were, I think the phrase that was most commonly used was just an additional layer of bureaucracy, and that there's significant duplication between LHINs and CCACs. In their view, a more streamlined system by merging LHINs and CCACs. So that dynamic really reflects the interplay between the technical expertise of the ministry who advances policy ideas and the decision-making power of the political arm of government. Okay, so I'm going to turn and see if there are any questions that people have at this early stage. It doesn't look like there are any at this point. So what we're going to do is turn things over to Janine, and then we can address the questions at later parts in the session if you have some. Please feel free to ask anything.
Thank you, Dan. Before I get into the specific healthcare trends and realities that impact your sector, I want to just spend a few minutes putting healthcare reform in a much broader context. So when you're in the midst of a time of reform, it can really feel like this transformation is new, that it's really a departure from the past. But the reality is change has been relatively constant, and there hasn't been any major shifts in the system really for the last number of decades. What's happened, though, is the pace of change has perhaps accelerated in the recent decade. Over the last, really since the 70s, Ontario has tended to favor incremental change. There hasn't been this kind of wholesale system changes that you see in other countries. And there's been more consistency between the way different governments have addressed healthcare challenges than people might think. Some of this could be because the latitude to actually reform the system is constrained by our model of Medicare. The Canada Health Act, other legislation really determines what the public system will fund, what the provinces can actually do. Today we have Patients First, so that's the current government's health reform plan, and I'm sure many of you are familiar with different elements of it and are participating within some Patients First initiatives with your LHIN. But this should be really understood as the latest policy response to trends that have been with the healthcare system for some time. Some of these developments are more urgent today, but for the most part, they're not brand new. So I'm going to highlight a few of the milestones that have led us to where we are today. Many of you will remember the district health councils that were created back in the 70s by the Progressive Conservative government of Bill Davis. This was really the first policy to devolve planning to a more local level and really start to design services around the needs of geographic populations. So they were important, they represent an important kind of shift in terms of excuse me, regional planning and localized planning, but they were really planning and advisory bodies. They didn't have really any power to make decisions or manage that healthcare system actively. You may remember the Ontario Health Review Panel, also known as the Evans Report. That was essentially about health system integration and talked about the fact that one of the biggest problems was the silos between different parts of the system. It would be interesting to read that excuse me, that report again and see how relevant it is today. Back in 1996, the CCACs were created. Hard to believe it was about 20 years ago under the PC government as a way to really organize and standardize home care services, manage costs that were expected from the growing seniors population who is requiring more and more home and community care. There were at the time 42 CCACs, so they were actually tasked with coordinating home and community care at a much more local level than they do today. At around the same time, we had the Health Services Restructuring Commission, which some of you would have been aware of. And at the time, the government was wanting to deal with what they saw was mounting financial pressures in the healthcare system, but also they were concerned about the provincial debt. So they really wanted to rein in healthcare costs, and hospitals were the largest expenditure. So they felt that if they rationalized hospitals, that would be a way to get a more efficient system to reduce duplication and silos. At the time, the idea was also to push more care delivery out to the community in home care and primary care. So at the end of the HSRC's work, there were more than 25 hospitals had closed, and this was a dramatic disruption from a structural point of view, but it didn't necessarily result in the kind of fundamental changes that were originally envisioned. And one of the critiques at the time was that the restructuring in the hospital system wasn't matched by an investment and development of services outside of hospital, namely community care, home care, and primary care. So in 2006, after a couple of years of planning, the LHINs came into being, and that was largely because the government recognized that they needed a more effective way to manage the healthcare system. It was too large, too diverse to manage centrally. They wanted to follow suit of other provinces that already had regional health authorities, and the idea was to give local providers more accountability for healthcare solutions on the ground. So they created the LHINs as agencies or entities that would look at the priorities of the system as a whole, not just look at individual providers or beholden to any one part of the system, but look at the system in its entirety and what the population needs. There's always been a governance debate about who should decide the priorities and who should be accountable for managing the system. What Ontario opted for was to maintain the provider boards as well as having the LHINs as an oversight body, so that there would be both top-down direction in terms of health care integration, but also an enabling bottom-up problem solving and some accountability on the ground. Now, the question will be now with this moving toward these sub-regions, how much control will the LHINs have and how much accountability will providers be allowed to have in terms of setting priorities and actually allocating resources? One of the things, though, that is starting to happen and will undoubtedly continue is that there will be more shared accountability. So more and more where groups of providers across the system will be accountable for delivering the same things, the same outcomes for the populations they serve. And you'll see this in terms of, more providers having MOUs together or other forms of agreements, and even moving to having single accountability agreements, so where groups of providers have one accountability agreement with the funder. So this next slide is really about patients first, and one thing to bear in mind is that patients first really does build on past reforms from the Liberal government, as well as some of the ones I listed previously from previous governments. But there are some unique aspects to it that really have implications for community and home care and primary care. So I'm going to just highlight a couple of them. The first is that the government decided to further devolve management of healthcare to even more of a local level with the creation of subregions. So the LHINs are responsible for creating these subregions, and they're essentially networks of providers from across sectors that are responsible for delivering a group of services within a geographic area. So these are services that have been determined need to be available to people close to where they live. And the providers are jointly responsible for coordinating these services and achieving a common set of goals for their population. And many of you will be involved in the subregions different ways, and most the subregions actually have hospitals or community providers or primary care providers who actually have designated leadership roles in terms of the contributing to these connected networks. The next aspect of Patients First that affects you is a focus on creating a better integration between home care, community care, and primary care. So part of that is the merging the CCAC's roles into the LHINs, which is seen to be key to creating better linkages between home and community care, and you all know that there has been, largely because of structural reasons, some fragmentation between home care, so the more nursing and clinical services, and the other community support services that are provided to people in their homes and communities. But also part of this was creating better connectivity between primary care, community and home care, and long-term care, really, on a local basis. The other big change is that the LHINs have an expanded mandate. Now with this, because they've taken on CCAC roles, they're not only planning home and community care, they're actually directly delivering some of those services, including being responsible for the care coordinator role that CCAC is used to provide. And now the LHINs are also responsible for planning primary care services, so creating a plan that encompasses primary care. This is a challenge for LHINs, of course, because they don't fund or have authority over most primary care. So it remains to be seen how much leverage they will have in terms of trying to organize a primary care system that still is largely based on solo practitioners. So what to do when the political situation is uncertain? Obviously, there could be a change in government, and the situation is going to be fluid. I want to just reinforce that given our history of incremental change and the fact that our healthcare system is pretty deeply institutionalized and entrenched, we should not expect that there will be any dramatic changes. Moreover, the public usually doesn't want major disruption in the healthcare system. They do want improvements, but they don't want any dramatic changes. So there may be changes, though, that won't be insignificant for you. Depending on the government or whether it's a majority or minority, there may be different levels of increases in funding overall. There may be base funding increases or no base funding increases, and each government will target funding differently to different kinds of sectors and solutions. So how can healthcare providers keep moving forward? Well, we're going to talk a little bit more in depth about this at the end of the presentation, but really I want to just put out there now that it is important not to wait until you get some clear top-down direction. In fact, the system is set up so that it does allow for a lot of innovation and leadership from the ground, and your organizations should continue to do that. And also, if there are times of disruptive change in some areas, this can be an opportunity for you to start to put forward additional different solutions that you believe will improve client care. So now I'm going to get into some of the trends and realities that transcend any government going forward. The first one is this trend to focus more on outcomes, not just outputs. So historically, the healthcare system was funded based on activities and volumes. But we've realized as we get better data and evidence that providing more and more services, or providing services using traditional models that are outmoded, doesn't necessarily translate into better health outcomes for the population. Plus, funding activities is really hard to manage. It's really hard to manage costs. When you fund just activities and volumes, the incentive is to provide more and more services, not necessarily to improve the impact or the outcomes of those services. So over time, there's been a move toward expecting outcomes for funding provided. So hand in hand with this is that we're getting more and more better data and ability to use evidence to assess whether the things we're doing are the right things and whether they're actually improving people's, not only their health, but their experiences in the healthcare system. The Excellent Care for All Act, which was passed in 2010, was really an important piece of legislation in that it gave governments and the LHINs a basis upon which to stop paying for things that either the evidence showed didn't improve quality or where they were paying too much for the level of outcomes received. There's a lot of examples. One high-profile one was vitamin D testing, where there was the evidence that vitamin D testing and the overuse of vitamin D, or taking of vitamin D, didn't actually contribute to better health, and in fact was an unnecessary cost. HQO actually advanced this, and the government had a basis upon which to stop paying for routine vitamin D tests. There's many examples of the ministry and the LHIN using different kinds of agreements to expect outcomes for the money that they provide. So LHIN accountability agreements, for example, now providers are not just accountable for providing the services that they've always provided, but to meeting outcomes that are more based on actual health improvements. And primary care has been moving incrementally away from fee-for-service or volume-based kinds of models to capitation models. So now there's more and more physicians are being compensated based on the number of patients that they receive, and they're incented to actually provide comprehensive care rather than more trying to churn as many patients through or provide as many interventions as possible. So this is an example of funding reform in Ontario and where it's going, and really every sector of the healthcare system is being impacted by funding reform. Most of the kind of novel or innovative approaches to funding reform have been used with hospitals, but now the government's using something called bundled funding to actually fund services that are provided collaboratively across hospitals and community agencies. So you've probably heard of the bundled care pilots that have started with focusing on patients who are transitioning from hospital back to home. So this is, in these pilots, groups of hospitals, home care providers, as well as some community agencies receive funding to support a group of patients who are moving from hospital to being stabilized back at home in the community. And there's some thinking that the LHINs will want to move forward to more in using these kinds of approaches in the way that they pay for home and community care. So for example, standardizing what they pay for certain community services, including CSS services as well as mental health and addiction services. So what this might mean is that the LHINs will pay one provider, a group of providers, for a particular service at a particular standard for one price. And they'll be zeroing in on services where there's a lot of variability in terms of what they're paying from one provider to another, or what they're paying from one LHIN to another, and also services where they can see that there's clear gaps where there's populations that aren't receiving an equal level of access. So the next trend is cost containment and efficiency. So we discussed quite a bit in webinar 1 that Ontario has constrained healthcare spending for the better part of the last 8 years and kept spending down to lower levels than many other provinces. Increases in healthcare overall have tended to be between 1% to 2%, barely keeping pace with inflation. And at the same time, we know that demand has grown and continued to grow exponentially. So this chart here shows on the slide shows that in 2015, Ontario had one of the lowest per capita spending on healthcare. At the same time, there have been investments in Ontario in community and primary care. Because this is seen as a way to not only improve health outcomes, but to reduce cost pressures overall. So the community sector has seen roughly a 6% increase in recent years, year-over-year increase. But of course, as you well know, the funding has not been in base increases. So not every agency, not every provider has benefited from this overall increase. And the increases have tended to go to expanding services or supporting the introduction of new programs or models. So it hasn't gone to meeting the current demand, nor has it gone to address a lot of the operational pressures that you feel every day. So, and also the investments are perhaps not sufficient to meet the growing demand, as there's an influx of more clients who are receiving care in the community rather than hospitals. So in many ways, necessity has been the mother of invention in the community and primary care sector. And even through this time of constraint, there's not been any major reductions in services because organizations really have been very creative and put a lot of effort in becoming as efficient as possible within their own organizations and sectors. And the government, LHIN, and providers together have made significant changes in the way services are organized and delivered. So there's more sharing of resources today. Organizations are joining together with others that have different capacities than they have, maybe different kinds of infrastructure expertise, and there's more interdisciplinary team-based care across all areas of the system. But I think it's becoming clear to everyone, in the government included, that we may have reached a breaking point in terms of finding or eking out efficiencies from within organizations themselves. And really, if community agencies were to become any leaner, many of them would simply be unable to operate, and it would start to impact client care. The province's own Financial Accountability Office put out a report recently that said that funding in Ontario is not keeping pace with demand and could compromise the quality of care if it's not addressed. So the government, not surprisingly, announced in its recent budgets a significant increase in healthcare for hospitals in the community sector, and it is most interestingly the first base funding increase in some time. So while we don't expect that the spending levels will go back to what they were, and certainly won't go back to double digits, there is a recognition that we need to rebalance the system and invest in building capacity. One of the most significant trends that will continue, though, and everyone realizes, that we won't be able to meet the demands of the aging population, changing population by providers acting alone, and then more providers are going to need to share resources and find collaborative solutions. And that also, that a strong, well-coordinated primary care and community care will not only improve the health of the population, but it's really the only path to financial sustainability. So the third trend is this continuation of shifting healthcare out of hospitals and institutions. We undoubtedly will continue to see more care being provided outside of hospitals and a reduced reliance on hospitals. Some may wonder if this trend is going to continue because there's been a big media focus lately on hospital overcrowding and a lot of recent announcements about hospital funding. But I think that's probably a reflection of the fact that the province may have squeezed hospitals too much in recent years. Their budgets have been flatlined for a number of years, while the community sector has seen at least some incremental increase. So this is really about trying to recalibrate the system so that we don't experience quality of care issues in hospitals and deterioration. But no one thinks that this recent reinvestment in hospitals is actually going to alter the overall course of healthcare reform. The focus will continue to be on strengthening care outside of hospitals. Another important trend to flag is that hospitals themselves have been taking a leadership role in shifting care into the community. They know that it's key to their own sustainability, but it's also preferred by clients and patients. People want to receive care close to home. They want to stay home, age at home if they have the option to. And what hospitals bring to the table is infrastructure and capacity and some expertise that's necessary to create coordinated service networks. So you're seeing things like the Sinai Health System or the St. Joe's Health System in Hamilton, where hospitals are playing a lead role in creating actually a coordinated healthcare continuum. And they're doing that by merging with rehab hospitals, acquiring home care providers, and actually actively integrating with local primary care. There is an active debate about whether hospitals are best positioned to play this kind of a leadership role in creating integrated community-based systems. And also there is some thinking that the best results will come from community primary care and hospitals really co-leading and co-creating these interconnected systems together, and that bringing their respective strengths to the table. So hospitals bring that infrastructure and expertise, but communities have this deep knowledge of their own communities and this understanding of the social determinants of health and how to work across sectors to improve healthcare. So this kind of collaboration among all of the sectors is what's really happening in the subregions, with no one sector kind of dominating or leading the system integration at this point. The fourth trend is the trend toward decisions being based on data and the use of digital health. So having good information, having strong connected information systems to be able to share client information, to plan, to measure and improve performance, they're all obviously crucial aspects of a high-performing healthcare system. But Ontario has had a mixed experience with digital health so far. So within sectors, there has been investments in innovations, and certainly your associations have taken a leadership role in trying to put forward proposals and getting some investment in digital health and building information infrastructure within your sectors. And the LHINs themselves have driven a number of initiatives to try and link up data between sectors. And we certainly have a much better ability to not only gather data, but to understand data at a much more local level. So we have much better understanding what populations need and the healthcare services at a very local level. And EMR adoption, electronic medical record adoption, has been very high in primary care. Most primary care providers have some access to an EMR. But we still largely don't have the ability to share client records, patient information seamlessly and consistently between sectors and providers. And it's been really difficult to link information to manage care across the system, across the continuum. And we're also behind on engaging clients and patients in using these digital health technologies to communicate with providers, to actually be active participants in their own care. One of the examples of how siloed the digital health system is for patients is the example of patient portals. So hospitals have been innovative in creating these portals for their own patients. So patients can access information about their care at that one institution and maybe a bit more of their care. But what's happening is some patients actually have multiple portals, each of them giving them a slice of their information, a slice of their health record, but not the total health record. So they don't yet have one place they can go to get all of their health information in one place. So in that case, many patients are simply just not using the portals because they find them it's just too confusing. The fifth trend is the emphasis on population health management. And really, this is a very positive development that represents a big opportunity for community health providers, because the emphasis is looking at how to improve the health status of the entire population and how to actually prevent health disease and improve overall health status while reducing inequities in access and outcomes between different groups in the population. So this is totally aligned with the philosophy that your sectors have taken, that upstream investments in prevention and supportive services can actually have an impact down the road in terms of improving people's health overall and frankly reducing costs in the long term. It has been traditionally hard to get traction and investment in preventative health, community care, let alone the social determinants of health, because it's been hard to prove that investing in some of these services will actually lead directly to better health outcomes. Even people know intuitively that focusing on improving overall population health is better in the long run. It's been hard to get the hard numbers to link service A with outcome B. But now that we are moving toward more interconnected data to show more cause and effect, we can better make business cases for investing in population health management. The sixth trend is something that is really top of mind for all providers, and it's something that you're actively dealing with as organizations. When we talk about integration, it really does mean different things to different people, and there's many different perspectives on it. What we're going to do is try and provide a perspective of what the Ontario experience is and really what integration is meant to mean and how it's really unfolding in Ontario. It's fair to say there's not only interest in it, but there's a lot of confusion and even some anxiety about integration in Ontario. But all systems across the world have had to address integration, and that's simply because no one part of the healthcare system can provide all of what people need alone. And in Ontario, there was a realization that people get good quality care. Their experience is really good within individual organizations, within services, once they get into care. But it's the movement between the services, it's the care transitions that don't work as well, and that's where there's the greatest dissatisfaction. So Ontario put integration front and center as a mechanism to achieve better quality, better seamless experience, and hopefully a more cost-effective healthcare system as well. And the LHINs have been created as that mechanism to create a system. So to create a system out of what has been in the past individual providers and sectors. And patients first, the current reform strategy really emphasizes integration. So integration between sectors, not just within sectors, but between primary care and community care, between home care and community support services. And not only that, between health providers and all of the non-health care organizations that have an impact on health, such as municipalities and social services providers. So it's really important to understand, though, that integration was never meant to be an end unto itself. It was always meant to be a means, one strategy among other strategies. And the other important thing to consider is that there's no reason to think that Ontario is going to be putting the brakes on integration anytime soon. The question will be rather, how will integration be driven? How much top-down direction will there be? How much freedom will there be for providers to actually determine how integration will work from the bottom up? And at what speed and intensity will integration occur? So next slide is really wanted to point out that your organizations have actually, and your associations have taken a leadership role in terms of trying to define what integration means. And Community Health Ontario, which is an umbrella organization that kind of brings together OCSA, AMHO, CMHA, and AOHC, actually put out a paper around integration, and we're going to provide that to you in the portal after that, where you can access materials. But in this paper, if you haven't read it, the emphasis is on, at the end of the day, what we're trying to achieve is a better integrated experience for clients. And so integration should be looked at in terms of how the outcome for the clients. And there's many, many different strategies and ways that integration can come about. In fact, there's a lot of integrative activity that happens every day in, that your organizations are involved in that doesn't formally go through any kind of oversight or approval process by the LHIN. This next diagram we thought was really helpful. It's from the Toronto Central LHIN, and basically in 2016 they undertook a review of their role in integration and created a framework and a toolkit to help providers really understand what integration means and help to guide them in their own decision making. So this was taken from that report, and it was created by Optimus, which is a consulting group who did this work for the Toronto Central LHIN. And we think it's really useful for organizations in any part of the province. So oftentimes people think about integrations and they go to mergers. They think integrations are about structural integrations or full structural integrations. And of course they are. Mergers are one sort of integration, and there is, utility in mergers. Sometimes that's maybe the right solution. But really integration is a whole continuum of activities, and that should be thought of as integration. So you should think as broadly as possible about integration. So I'm just going to go over what the continuum is here as a helpful way to think about it. On the left side, it ranges from everything from having informal networks and where organizations share practices, either a one-time arrangement or ongoing around a certain kind of set of services, to more formalized partnership agreements, to creating standardized pathways that all providers must follow. And including things like coordinated intake, coordinated referrals, and single access programs. It goes all the way to merging specific programs and services, such as back office integrations, where one provider will provide back office on behalf of a number of different providers in an area, or clinical services being integrated. And then, of course, on the far right, the ultimate form of integration is a full merger or amalgamation. In regional health systems, they've got a fully merged service system because they've really only got one provider, which is the regional health authority for an area. under one board. So a lot of your organizations, you can see when you look at the continuum and probably recognize a lot of the activities that you're doing are actually some form of integration. But you're also, I'm sure many organizations are looking at how they can more formally plan and pursue greater integrations that will not only meet the needs of their clients, but position them more effectively in the system. So the beginning point for thinking about integration should always be being really clear on what you're trying to accomplish. What are your objectives? And form of the integration really should follow function. So it may be that you're looking for greater financial sustainability. You may be that you lack capacity in a certain area like IT or training, and you want to join together with another organization that has strength in those areas. You maybe want to offer a broader array of coordinated services to the population you serve. Your population's changing and you need to provide something that you currently don't have in your basket of services. There's a whole host of reasons why organizations will integrate. So we just wanted to go over really quickly 3 examples of how integration is actually happening, and more integration is happening more at a geographic level where organizations across sectors are working together in an integrated way to provide a more seamless experience for and more equitable experience for the populations they serve. The first example is the Sinai Health System, and that was really initiated by the hospital itself, and that was where they wanted to create an integrated system of care for a particular population, which is complex seniors. So they did that by merging with Bridgepoint, which is a rehab hospital, and then also acquiring a couple of family health teams within their system, and then actually acquiring a home care provider. So they're providing more of a continuum of services that their complex seniors population, geriatric population needs. The next one is the Muskoka and Area Health System Transformation. So this initiative started actually prior to the subregions, but this was really an effort to organize services in an area that is actually one of the subregions now within the North Simcoe Muskoka LHIN. So at the time, the North Simcoe Muskoka LHIN created a council that brought together not only health service providers, but municipal leaders, social and community services, a number of players who are involved in health-related programs to one table to come up with a single plan for providing services to the people of Muskoka, including Bracebridge and Huntsville. This was very ambitious, and now the work that they've done and the partnerships that were created will now be able to be taken on by the subregion to actually, so they've really got a head start in organizing the healthcare system within that subregional area. And then, of course, the government has had an interest in hubs, and so the Premier actually appointed somebody to lead a hub strategy. And so you're seeing more and more hubs happening that are being funded or incented in some ways or supported by the government. But I must say the community sector and CHCs in particular have taken a real lead role in terms of helping to foster these hubs. This is just an example of one that the government, an initiative that the government announced back in February of last year, which is the creation of integrated service hubs for youth, where they bring together, it's basically a one-stop shop for not only health services, but education, employment, and other community-related services that youth need. So finally, this is just to go back to the local health integration networks. It's in their name. Obviously, the LHINs are really the driving mechanism for health system integration. So really thought it was important for you to understand, if you don't know, that the LHINs have powers to integrate the system that are embedded in their legislation. And there's really 3 ways in which the LHINs can help to advance and bring about integration. First of all, they can use funding to incent organizations to provide services in a more integrated fashion, and more they're doing that, where they're saying, well, we won't pay individual organizations to provide a service or a solution. We're looking for groups of organizations to come forward with a collaborative, a collective solution to delivering a service. They can also be more directive than perhaps some of them have in terms of selecting integration priorities and really driving and directing integrations in the system. So they do have the ability to facilitate and negotiate, actively negotiate types of integrations that they think will better serve the population and improve the system. And you're probably most familiar with the third one, C, on that list, which is voluntary integrations. And that is where the integrations are voluntary and driven by the providers themselves. Oftentimes with the encouragement of the LHINs, and sometimes with some support in terms of seed funding or tools, but these are really provider-driven integrations, and that most of the integrations in the system have been voluntary. The LHIN's role in voluntary integrations is they do have to, their boards have to review all the voluntary integration proposals that come forward, and they do have the ability to actually stop integrations if they don't think that they're in the interest of the system. Now, the focus for integration is going to be largely geographic, with the subregions as the focal point for integrations. And so now, as I had mentioned, you're starting to see that the LHINs are actively funding groups of providers within subregions for collaborative kind of services or solutions at the local level. And I want to say that you know, many of your organizations are sitting at the subregions tables. Some of you are playing, you know, your organizations yourselves, or you know, members of your sector, or actually have a lead, some kind of a lead role in subregions. It is quite possible conceivable that the LHINs, or as this regional model continues, that these networks will become more formalized, and they may move to things like actually appointing lead agency or lead agencies who will be responsible for the overall coordinated care plan, and actually will be responsible for dispersing or allocating funding from the LHIN within their areas. So we could see a more of a formalized role, but I think the important takeaway from this is there's an opportunity to be active in your subregions and actually shape the form in which the subregion governance and the kind of the funding allocations will actually work within your subregions. So now I'm going to pause before we go into the last section and see if we have, and we do have some questions. Great. Okay, so the first one is from Deborah and Simon of the OCSA. The real question around transformation is, how do we continue to support home and community, mental health, primary care, and hospitals for that matter, while we transition to more community-based service delivery, especially with a deficit growing in Ontario? Do we have any ideas on that? My voice, I'm gonna have to take a sip of water. Dan's looking at me going, you take this one, but I'm gonna let Dan start and then I'll jump in.
I think that the question that Deborah's asked is really no different than the question that the government has been grappling with over the past number of years, which is, how do you continue to affect this transformation when fiscal resources are constrained and there's really not enough money to go around to meet the expectations of service providers and the demands of patients. And I really think that how this has been positively accomplished, I guess, we've seen things really work out well, is where new models of care have come together. And as Janine talked about, necessity being the mother of invention, you know, we're doing a project at the moment for the Toronto Central LHIN, where we're looking at some of the integrations that have occurred, voluntary integrations, where providers have come together and decided to more, in this case, more formally merge. And in many cases, it's the providers themselves who are reporting that new kind of strategic mergers have really enhanced their capacity to be able to address client needs and increase their service levels without necessarily new funding, net new funding available. So it's not a panacea, it's not a solution, but there are some pockets where you're seeing very innovative service models emerge, not just within a sector, but across a sector. And you've seen organizations really undertake strategic alliances and partnerships that have had a tremendous impact for those organizations and the clients, and that's what those organizations are reporting. So I think from the perspective of an association, it's continuing not only to advocate for the interests of the individual members, but to be able to take on a role in sharing kind of emerging best practices and learnings across the membership that will help them navigate this very challenging dynamic, and really continuing to advocate for support at the ministry level and with LHINs to be able to support in a way the transactional costs and the transitional cost between where some providers find themselves today and where they'd like to get to in the future.
Okay, the next question is, with the integration that's been occurring, and I've recently went through one, how does the funding work? Well, I can start with this one. I guess, you know, there's all different forms of integration, but I'm going to really talk about ones that are more to do with structural integrations of programs and services or whole organizations merging together. The whole idea is that the merged entity at the end will have the same combined operational budget. The LHINs have not been inclined to increase the base funding or the operational funding, but rather expect that the combined entity will operate with the same budget. But the expectation and the hope is that over time, maybe not immediately, certainly not immediately, that the two organizations or more, or multiple organizations in some cases, will be able to find efficiencies by coming together. So that the idea is that through having single administration services, single finance department, single HR function, single information systems, one audit, like all of these things, that over time that will actually help to alleviate costs, but I think the experience so far has been that these kinds of efficiencies and any cost offsets are not realized right away, and that there is a significant investment that goes into restructuring or merging organizations. So there's always going to be a cost up front to structural integrations, with the promise of, in the long term, finding cost efficiencies. Some LHINs have been willing to provide one-time costs, one-time funding to organizations to help them with the costs that they're incurring for mergers. So things like everything from legal services to project management to helping support even putting together even a business case for the integration, and then the ongoing costs that are involved in harmonizing IT systems and you know, changing any changes in facilities. There's all kinds of costs, that the one-time costs. So that, but not, I do understand that not all LHINs have the same approach to providing one-time funding, but we do know that community agencies find it invaluable to get that one-time funding, and in fact many of them would not be able to move forward with, are reluctant to move forward with the structural integration without kind of this funding support. So I don't know, Dan, do you have anything else to add on that one? And I think we have time for one more question, which is with integration, what happens to staff who do not come over when there's a program transition? I think one of the requirements, I'm just going to talk about integration in a LHIN context. The requirements that LHINs have, if it's a voluntary integration that comes forward, is that they will all have an HR adjustment plan, so that every integration is thought through how have an HR plan, and also if they're unionized environment, that obviously they have a labor relations plan and they're working in lockstep with the unions. So and the idea is that integrations are not supposed to be disruptive to certainly to client services, but also not to disrupt you know, the workforce and really to be to be smooth and seamless. So I think that, you know, these are decisions in terms of staffing that the organizations have to decide, but I think you can look to some guidance from the LHIN and the expectation that staff will be supported, whether they are directly impacted by the programs and services that are being integrated or not, that there will be this, you know, thoughtful plan, and that in fact that staff will be engaged, actively engaged in the integration planning as well. So I think now we're ready to move on to the last section, and over to you, Dan.
So I'm going to wrap things up with looking forward a little bit, and really what you can expect out of the three main political parties, and what they're putting forward in terms of their healthcare priorities if they were to form government. So I'm going to start with the Liberal Party, and perhaps their plan is the most flushed out, and that's, you know, in large part related to the fact that they've been in government for 15 years, but also it's linked to the fact that the Liberals just tabled a comprehensive budget at the end of March that really outlines their investment priorities over the next number of years. And this is really it's really the basis of the Liberal Party's political platform that is expected to be released in coming weeks. And it's important to note that many of these budget commitments would only move forward in the case that a Liberal government was elected after June 7th. So in many respects, the budget was a communications document to the sector and to the public about what priorities it has in the health sector and in other areas of the economy. So the first thing to note is that the budget commits the government to invest almost 5% more each year in healthcare, which is part of the reason why the budget projects the province going back into deficit. It's a pretty significant increase in healthcare expenditure compared to the 1% to 2% level that we've had over the past decade or so. And this spending in the budget is directed pretty much across the board, but you know, some of the highlights are $822 million for hospitals, $2.1 billion over 4 years for mental health and addictions. You know, reiterating the commitment to 30,000 new long-term care homes beds, $650 million for the home and community care sector over 3 years. The plan also included an expansion of the drug coverage to eliminate co-pays and deductibles for those over 65. So essentially, if they were to get elected and this budget was to be implemented, everyone under 25 and everyone over 65 would have access to all the drugs on the formulary free of charge. Their plan for the people not captured by that program, I guess everyone essentially from 25 to 65, was to introduce a new drug program that would also include coverage for dental care, where people would be, it's not entirely clear how it'd be rolled out, but essentially covered for up to $400 per individual or $700 for a family for drug and dental costs. Now, the NDP is committed to a very similar spending plan to the Liberal Party, although they highlight, they highlight a few different changes. On the hospital side, it's very, very similar in terms of committing to address hospital overcrowding, and they include a commitment to maintain hospital spending at minimum at the rate of inflation. What's kind of different is that the NDP says that they'll place, if elected, an immediate moratorium on all layoffs for frontline healthcare professionals, and that what they'd want to do is develop a kind of comprehensive integrated healthcare human resources plan first before there could be any change or movement within the sector. The other two things to note are just the introduction of almost a dueling or competing plan for universal dental care and pharmacare. On the drug side, the NDP plan is more comprehensive in terms of the ages covered, that there's no age group that's left out, but they would initially provide coverage on a much smaller list of essential medications. So it's a broader coverage plan, but a little bit shallower is maybe the easiest way to think about it. They also talk about addressing the real lack of integration in mental health and addictions that people have been commenting on for decades, with the creation of a new mental health and addictions ministry. And there's not a whole lot of detail about how that would work and how services would flow out of the Ministry of Health and other ministries. And clearly, if elected, the NDP would have to, an NDP government would have to think long and hard about how it didn't create new silos between this new Ministry of Mental Health and Addictions and the existing Ministry of Health and Long-Term Care. So as for the Progressive Conservative Party, they're a bit of a wild card at the moment, perhaps the most unknown in terms of what exactly they would do on the health portfolio. Doug Ford made a kind of a big point on becoming elected at the party of really moving away from some of the commitments of his predecessor, Patrick Brown, and disavowing the party's platform, which Patrick Brown had titled the People's Guarantee, that had well over 100 commitments in it, and many of them focused on healthcare. So really, we don't know exactly what the priorities of the PC government would be in healthcare, and it's unclear as to whether they're going to release a detailed election platform in the run-up to the election. So really, all we have to go on is what they've said and what they've put on the public record. And these are some of the things they've said. They said in response, particularly to physician pressure, the PCs have said that they're going to listen directly to frontline workers to help find efficiencies and better deliver services. That language almost comes directly from the Ontario Medical Association. And I think, in fact, physicians have a pledge that they're asking candidates to sign that pledge governments to listening to frontline health workers. They also talk about providing more help and resources to the healthcare system. Again, a little bit vague and open to interpretation. Also, as the NDP has been doing, talking about eliminating hallway healthcare in hospitals and providing more timely access to care. And finally, this week, some of you might have seen it in the news, Doug Ford announced that if he was elected premier, they would not support safe injection sites, and that in combating the opioid crisis, there's clearly a preference for support and a focus on drug treatment as opposed to a harm reduction approach. And that's it in terms of where things stand on the party priorities. We'll see more, particularly as the Liberals and the Progressive Conservatives release more details about their public policy commitments. Just like to see if there are any questions about this. Okay, seeing none, I'm going to move us to wrap up. And the question is, I guess, in this environment where there's a lot of instability, a lack of stability, you're on the verge of a election campaign. There could be a minority government. Who knows after? The tendency for some people in this kind of environment is to say, we don't know what the government strategy is going to be. We don't know what the approach is going to be. Let's sit tight and we'll just react to what comes out. And our message to you would be that there's an alternative approach that puts your organization in the sector in a much greater position. And that is to take a much more proactive approach where you're not waiting for permission, but that you're instead using your understanding of the environment, using your ability to collaborate with other like-minded organizations and to define a value proposition and build solutions from the ground up that can really influence how a government, whatever their political stripe is, addresses the challenges in the healthcare system that, as Janine talked about, are really facing political parties of any stripe and really need that level of understanding and nuance that only can be provided by people on the front lines of healthcare. So understand the environment that you're operating in, define the value proposition that in alignment and collaboration with your peers, and take those solutions to decision makers so that you are driving the agenda and ensuring that, as a new government comes in that has some vague, potentially comes in, that has some vague ideas about how the healthcare system operates, that when they're making real policy decisions, that those are informed by a more nuanced understanding of how things operate at the front lines. So that's it. Thank you for your time today. And if there are any other questions that are put on chat, we'll be sure to respond to them later. Thank you.
Thank you once again to Dan and Janine for another incredibly in-depth and valuable presentation. I'd encourage you folks to please take the time to fill out the evaluation that will pop up as soon as you close the webinar. This link will also be emailed to you following the delivery as well. We'll use the results from these evaluations to inform the selections of themes for upcoming leadership webinars in the future. So please take the time to fill that out. The Leadership Project is ultimately concerned about delivering the content that you are interested in and that can support you best in your roles as leaders in community and primary healthcare. You'll also receive an email following this webinar that includes the slides, the recording, and a link to a Google Docs page with all of the supplementary reading materials. You may have noted this week that we have launched our new leadership website, which you can find at leadershipproject.ca. So come on over there and take a look at all the project information in our new site. This is where you'll get all the most up-to-the-date project information, including links to the Health Systems Leaders webinars and links to apply to upcoming cohorts across the province of our delivery of the LEADS 5-day learning series. We're still accepting applications for many locations across the province here, and we also will have plenty more locations coming up that will be launched probably at the end of the summer, so stay tuned for that. Come on over and follow us at LeaderShiftON on Twitter, and this is where we post a lot of our upcoming webinar deliveries and all kinds of highlights from the Leadership Project itself. Thanks again, folks, for your time. We know it's very valuable, and take care.